Good evening, sir. Good evening, viewers. Welcome to our Diabetes Essential 52 Weeks with Dr. Sanjay Kalra. Today we have interesting session on insulin regime and preparation. Before that, I would like to announce the winner of the last episode. So, Pratik, can I have the slides, please? So, starting with Delhi, Dr. G.S. Batra and Dr. Rajiv Handa. From Jammu and Kashmir, we have a regular winner, Dr. Sahid Hussain Sofi. From Jharkhand, we have got Apurva Viswas and Dr. Ravi Bhatt. From Karnataka and Satish Kumar Jain again from Karnataka. From Madhya Pradesh, we have Dr. Sasi Khare. From Odisha, we have got Dr. Gangadhar Rath, Pradeep Patro. From Punjab, we have got Namrata Puri and Dr. Sanjeev Puri. And from Uttar Pradesh, we have got Dr. S. Raman Tripathi and Surjit Kalsi. From West Bengal, we have got Shanturi Kumar Bhattacharya and Tanmoy Mitra. Then we have got from Maharashtra, Dr. D.J. Parmar, Dr. Dharmika Tandon, Dr. Girish Jesota, Dr. Hitesh Vora, Dr. Kulbhushan Tandon, Dr. Manju Vasudev, Dr. Poonam Sahani, and Dr. Suresh Pawar. One more announcement, as we usually do that, usually there are 3 to 4 tent pole event which we always have in the 52 weeks journey. The journey started with Dr. Vivian Fonseca coming and blessing us on April. Possibly again there would be a big announcement in the month of August. Again there will be a world-class faculty from Harvard we will be getting soon, who will be discussing diabetes essential with Dr. Sanjay Kalra. With this, I hand over the session to Dr. Sanjay Kalra. Over to you, sir.
Thank you, Mr. Basu, and greetings, everybody. It's a very hot Sunday evening here in Karnal. It's really, really, really hot. But the good thing is that monsoon is here in our country, and it should soon be with all of us. Let's continue with our journey, learning about diabetes care. And today we'll talk about something that's very important. We will talk about insulin regimens and insulin preparations. Now, in the past 1 year or so, it has actually been more than a year now, 13 months to be exact, that Dr. K.K. Agarwal sir left us. In the past 1 year, we have had many questions on insulin, on how to prescribe insulin. So let's try to make it a bit systematic, a bit structured today. And we look forward to your questions and comments. We also look forward to your best practices. What is it that you are doing in your field? So let's talk about insulin. Now, whenever you want to prescribe insulin, there is a stepwise approach. First of all, we decide that we need to give insulin. Then we decide the regimen. Then think of the preparation, the concentration, the delivery device, and the titration schedule. If we follow this stepwise approach, we will not make mistakes. So just remember once again, first decide the regimen, then decide the preparation, the concentration, the delivery device, and then give your patient a titration schedule. But when we look at this slide, suddenly we get afraid. How do I do all this? How do I decide? So let us make it simple over the next 20-25 minutes. Let's try to structure this. How does your patient define insulin regimens? For patient, it is very simple. Patient will say, sir, for me, all the insulin regimens can be classified as once a day, twice a day, thrice a day, 4 times a day, 5 times a day injection. So it is a number-based classification that the patient has. For us, in our mind, we have a different classification. We classify as short-acting. Even within short-acting now, we have short and ultra-short-acting. So we classify our insulins as short-acting or ultra-short-acting. That is 1. Then intermediate-acting or long-acting. That is 2. And when we put them together, we get premixed and co-formulation. So it becomes much easier. Now we have short-acting, long-acting, and premixed. Within short-acting, we have human insulin, regular insulin. We also have ultra-short-acting analogs like aspart, lispro, glulicine, and fast-acting aspart. In the long-acting one, we have human insulin, which is NPH. The full form is neutral protamine hagedon. Neutral is because the pH is neutral. Protamine is because this protamine, which comes from the sperm of the salmon fish. This is added to regular insulin to increase its duration of action. And hagedon is the name of the scientist from Denmark who discovered this. So neutral protamine hagedon, this is intermediate acting. But we have insulin analogs also, which are long acting, like glargine U100. And then we have detemir. And we also have ultra long acting analogs like degludec and glargine U300, units 300, that is 300 units per ml. Some of these can be combined. So you can combine to give a premixed insulin. We can have biphasic human insulin, which contains both regular insulin and NPH. We can have biphasic analogs, which will contain aspart plus protaminated aspart, lispro plus protaminated lispro. And also we can have co-formulations, degludec and aspart. Now, this is also complicated. So let us do the common trade names. And please excuse me if I've forgotten any of the trade names. We have so many now, and even more are going to come next year. But if there is any trade name that you are using and you are not sure about how to classify, please put it up in the chat box. We'll discuss. So the short-acting analogs that we use they're all named as rapid or R. So you have ACT rapid, which is the human insulin. You have vosulin R or exulin R or huminsulin R. These are all regular. You have ultra short acting ones like novorapid, fast acting aspart, and humalog or eglucent. Epidra is also there. The intermediate acting one, that is NPH, that would be insulatard, or some of the companies will mark it as N for neutral. So huminsulin N, for example, or insulatard. And the long-acting analogs, the common ones are Lantus, Basalog, Glaritus. These are all glargine U300. Tugio is glargine U300. Levemir is injection detemir. And Tresiba is injection degludec. In the premix category, we have Mixtard, which is human. You can have Mixtard 3070, Mixtard 5050. We also have Vosulin 3070, Xsulin 3070, and Huminsulin 3070. In the biphasic analogs, we have Novomix and Humalog mix or Eglucent mix. You can have Novomix 3070, Novomix 5050, Humalog 2575, Eglucent 2575, Humalog 5050, and Eglucent 5050. And in co-formulation, we have injection Rhizodeg. Another trade name of glargine, which I forgot, was Basaglar. This is one of the larger selling insulins. That is glargine U300. So we've understood, and again, there are so many trade names, we'll get confused. So what I suggest is that you stick to any one or two trade names, whatever you are comfortable with. And you should have in your kitty, in your pharmacy, at least one trade name of each group. So in the short-acting insulins, you may wish to choose any trade name from regular, aspart, lispro, glulicine, or fast-acting aspart. In the intermediate acting, one trade name from NPH. And in the long acting, Levemir is not sold so frequently now, so you would choose one glargine or maybe glargine U300 or degludec, Tresiba. And one more that you should choose would be the premixed, which can be any kind of a premixed, human or analog, whatever suits your practice. Let me spend just 2 slides on ultra fast acting insulin. So fast acting insulin is already available, like we have given the trade names, Novorapid, Humalog, Eglucent. But ultra fast acting is FIASP, faster acting aspart, which acts even faster than aspart and mimics the physiological release of insulin from the pancreas. So this prevents postprandial surge of glucose, and it also prevents preprandial hypoglycemia because the duration of action is less. This will be useful in type 2 diabetes, also useful in type 1 diabetes, and it can be used in insulin pumps. It will also reduce glycemic variability. The advantage of using an analog is that there's a lot of freedom. If you give regular human insulin, then you have to give it 30 minutes before a meal, ideally. But if you're giving an analog, you can give it just before a meal, 5 minutes before a meal. In fact, FIASP, faster acting aspart, you can take even 20 minutes after starting a meal. So there's a lot of flexibility, and this helps when you're treating children or elderly people, or when the person himself or herself is busy. These rapid acting insulins are also useful not only as prandial insulin regimens, but also as part of basal bolus regimens. Now we've used the word basal bolus, so let us come to types of regimens. The simplest one is basal insulin. The commonest one that is used in India is premixed insulin or co-formulation. And then some that some people use are basal plus and basal bolus. Physiologically, and for type 1 diabetes, it is basal bolus regimen which is the ideal. You give one long-acting injection at night, which leads to basal control. And then you give bolus 3 times a day with 3 meals. So total, you have 4 injections at least, multiple injections. It is a bit more complicated to teach. Patient may go into hypoglycemia, and you have to teach the patient how to adjust carbohydrates and dose. A lot of motivation is required. So if your patient has type 1 diabetes or is very insulinopenic, is very symptomatic, is very sick, needs swift resolution of hyperglycemia in order to resolve the underlying medical, surgical, or obstetric comorbidity, then basal bolus insulin is preferred. If your patient has a life-threatening, limb-threatening, organ-threatening, or function-threatening disease, which will be resolved only by quick resolution of hyperglycemia, then basal bolus is the best way to go. In a normal OPD, at the most, I think 10% of patients will require basal bolus. So therefore, we have simpler regimens. The simplest one to use is basal insulin regimen. This is effective and safe in persons with type 2. So if someone has just experienced OAD failure, then you start with basal insulin. It will help control the fasting glucose, but it will not act upon postprandial hyperglycemia. For that, you will have to give drugs, which can be DPP-4 inhibitors, which can be sulfonylureas, which can be repaglinide, which can be agarpose or voclibose. So in some patients, basal insulin will work. It will work by controlling fasting glucose. The commonest regimen that is used in India is premixed or sometimes co-formulation. This is easy to use, easy to teach. It offers both fasting and postprandial glucose control and helps in controlling HbA1c. Hypoglycemia is minimal. You can give premixed insulin once a day or twice a day. Usually we use twice a day, but if you are using once a day, you will give it with the heaviest meal. Now let's look at these regimens once again. If we start with basal insulin, this is what is advised by the American and the European guidelines. We start with one injection, continue whatever other drug you are giving. Hypoglycemia, weight gain will be minimum. Fasting glucose will come down, but PPG may or may not come down. HbA1c will not come down so markedly. And if you have to intensify, then you will have to add a bolus insulin. You do not necessarily have to go to basal bolus, that is basal plus 3 bolus. You can also do basal plus. Basal plus means basal plus 1 bolus, basal plus 2 bolus. So you give it with the heavier meals. Another way of starting, which is most commonly used in India, and I use this in my clinic, that is premixed insulin. We start with 1 or 2 injections. If you're starting with 1 injection, you can give sulfonylurea at the antipodal meal, which means the opposite meal. So if I'm starting, let us say, Mixtard or Novomix or Eglosent or Humalog with breakfast, I will continue my glimepiride or glycoside with dinner, and vice versa. This helps in achieving good HbA1c, fasting, and PP control. If we have to intensify, or sometimes we start directly with 2 injections, we can always use the same pen, the same preparation to intensify, and we move to 2 injections. If we do that, then we have to stop the sulfonylureas. There may be an issue with titration, but if you start slow and keep on going upwards slowly, there will be no risk of hypoglycemia. And you will be able to achieve control in the vast majority of people with type 2 diabetes. You will not be able to achieve good control in pancreatic diabetes or in type 1 diabetes in LADA. In these, basal bolus will be required. But still, if you're handling type 2 diabetes, what we do is, first, you can start basal or basal bolus or premixed, and you can always intensify. The general rules that I follow: if the HbA1c is very high, more than 8.5, then basal insulin alone will not work. You will need dual action insulin. So start premixed. If the fasting glucose is very high, more than 140, but the excursion PP minus fasting is less than 40, then basal will be a very good choice. But if the postprandial excursion, that is PP glucose minus fasting glucose, is more than 74, then we will have to give premixed. How did we get these numbers, 40 and 74? Let us look at the diagnostic criteria for diabetes. Post challenge 200, that is the diagnostic criteria for diabetes, and fasting 126. So 200 minus 126 is 74. That is how we got this arbitrary number. Let us look at the diagnostic criteria for pre-diabetes. Post challenge or post load 140, fasting 100. The difference is 40. That is how we got the arbitrary criteria for starting basal insulin. So this is the simplest method to decide. You can also speak with your patient and you can talk to her. You can say, the book tells us that we should start 4 injections a day. Look at what the patient says. If the patient steps back, that you feel she's going to run away, she's going to leave you, then say, yes, but since you've promised to take care of your diet and exercise, why don't we start with just 3 injections a day, or maybe 2? If on the other hand she says, yeah, I am fine with 4 injections a day, then you say, but I'm very confident that you will take good care of yourself, so let's start with 2. So you give the feeling that 2 injections are actually less than the 4 which was ideally required. And of course, if glucose doesn't get controlled after a couple of weeks, you can always intensify and go up to basal bolus. You also have to teach your patient a simple titration algorithm. The best is a 202 kind of an algorithm. So you tell the patient the target zone, let's say between 140 and 180. So if glucose is above 180, increase by 2 units. If it is below 140, reduce by 2 units. So that 202 is the easiest way of teaching. Like we said, usually we start premixed, but sometimes you may wish to start basal if the fasting is high, postprandial excursion is low. But do be aware that basal insulin will not give you sustained glucose control. You will sooner or later have to up titrate to basal plus. You will have to add a prandial insulin at the main meal. And finally, we will reach basal bolus. So it's up to us whatever stepwise approach we want to follow. You can start with basal, premixed OD, premixed BD. You can start with co-formulation, OD or BD, that is degludegaspard. When we intensify, we can intensify up to basal plus, premixed BD, basal bolus, or co-formulation BD. Premixed thrice a day is another way of intensifying insulin, but it doesn't work very well and I do not use it in my practice. We've spoken of various regimens. There is something known as split mix. So let me talk about this, because split mix is something that we used to use a lot earlier. In premixed, you have a premixed ratio. It is a fixed ratio combination, 30-70 or 50-50 or 25-75. But some people may not require exactly this regimen. So in some older type 1 diabetics who are not willing to take basal bolus, we do a split mix, which means first you take regular human insulin in a syringe, any number of units that is required. Then you fill NPH in the same syringe, and then you inject. So split mix means you are mixing it yourself. It is self-mix, not pre-mix. But we use in very few patients now. This was quite frequently used in endocrinology about 20 years ago. Split mix costs less. You can use it with vial and syringe. Conventionally, 2 doses are required. And if you're using human insulin, you will give 2/3 of the dose before breakfast, 1/3 of the required dose before dinner. Not before lunch. That's a typo here. It's before dinner. When we are using analogs, then we don't do 2/3, 1/3. Then usually we do 50-50 or at the most 60-40. So do remember the change in insulin distribution, dose distribution. For human insulin, it's 2/3 in the morning, 1/3 at night. And then you change according to titration levels, according to monitoring levels. If it is analog, you can start with 50-50 or maybe 60-40. 50 to 60 in the morning, 40 to 50 at dinner time. Do remember that patients also have a choice of user-friendly insulin pen devices as well. So you can use durable pens or reusable pens in which you keep on putting cartridges. And you can also use disposable pens, which you have to throw after those 300 or 600 units are completed. If you're using insulin for the first time, it would be a good idea to use a use and throw or a disposable pen. And if you know that the patient is going to use insulin for a long period of time, then you can get them to invest in a durable pen or a reusable pen. Most companies will offer their durable pen free of cost to you to give to the patient. So that is also something we should be aware of. We've talked about regimens and preparations today, and I anticipate a lot of questions and comments. But before that, let's look at our quiz for today. So our question is, which of the following elements, now suddenly I'm reminded of the periodic table, which of the following elements is needed for insulin to exert its maximal effect in glucose uptake? Is it vanadium, molybdenum, selenium, or chromium? Which of these elements is required for insulin to help in uptake of glucose? Vanadium, molybdenum, selenium, or chromium? Let's have the answers. And let's look at the questions and the comments for today. So lots of questions, and I'd like to thank everybody. Dr. Vinod Gupta says the best insulin regimen for a newly diagnosed type 2 diabetes. So that's if the patient is severely hyperglycemic, symptomatic, and sick, maybe with something like tuberculosis, diabetic foot, then basal insulin would be the best. But what is it that I use most often? That would be premixed. Because if you start, the patient is already so afraid and so worried. If you start on basal bolus, patient becomes even more afraid. So premixed is easy to teach, easy to explain. So that is what I use. Within premixed, I prefer analogs. The efficacy of human insulin and analog is exactly the same. But the tolerability, the safety of analogs is better. Analogs will cause less hypoglycemia, less glycemic variability. It is easier to teach analog insulin, and there is less troubleshooting because there is less glycemic variability. So I prefer premixed insulin analogs. Dr. Vikas Sonavane says criteria for starting insulin. So easy. Number one, if the patient is severely hyperglycemic, let us say the HbA1c is more than 10 to start with. If patient is symptomatic, patient has got severe weight loss, more than 5% of baseline body weight, and patient has got osmotic symptoms. So severe, symptomatic. Third, if patient is sick, patient has got an acute medical, surgical, or obstetric disease, which will resolve only if we resolve the hyperglycemia. So hyperglycemia is the limiting factor to treat any infection. Then we must start insulin. So if patient is severely hyperglycemic, symptomatic, or sick, we will start insulin. If your patient is in a special situation, hepatic impairment, renal impairment, pregnancy, lactation, again we must start insulin. And if your patient wants surgery and wants it swiftly, then we will start insulin for preoperative control. What are the figures? So there's no hard and fast rule, but if fasting is more than 200, PP is more than 300, HbA1c is more than 10%, then it would be a good idea to think of insulin. But think of insulin especially if your patient is symptomatic. Dr. DG Parmar asks if there is any data on safe drinking. So there is a lot of research, sir. In general, what is allowed by the international authorities is something like 2 pegs of 30 ml each for men and 1 peg of 30 ml for women, and they can take that daily. But there would be no absolute level for safe drinking. And we also have to look at other things like hepatic function, hypoglycemia unawareness, and the job of the patient. If the patient is, let us say, a public vehicle driver, then there is no level that is allowed, which is safe, because the patient is impacting not only his life, but that of other people as well. Dr. Jayalakshmi talks about contraindications and side effects of insulin. Okay, so thank you, madam, for raising this point. So there is actually no contraindication. This is what the literature says. But recently one contraindication, semi-contraindication has come up. That is patients who are taking a particular oncology drug. The name is alpelisib. It is used for carcinoma breast, and it is a PIK3CA inhibitor. Now, this particular drug, alpelisib, inhibits PIK3CA. This is actually an alternative route for insulin action. And because of this, sometimes it causes hyperglycemia. When the patient develops hyperglycemia, you have to treat with metformin and with SGLT2 inhibitors. Because if you give insulin, what it is said that the impact of that anti-cancer drug will be reduced. So this is one contraindication that I have read about recently, but there will be very few patients on this particular anti-breast cancer drug. But we must be aware of that. Apart from that, there is hardly any contraindication. Side effects can occur. So one is local side effects. We call them LSR, local site reaction. Pain, bruising, bleeding over the injection site. Lipohypertrophy over the injection site. How do we prevent these? By ensuring rotation of site and by avoiding reuse of insulin. So if your patient keeps on injecting in the same site using the same syringe, then lipohypertrophy is bound to occur. Apart from these local site reactions, there can also be amyloidosis. It is called insulin-associated amyloidosis, but it's very rare. And you can have hypoglycemia. So to prevent hypoglycemia, you must choose the regimen and the preparation with care, and you should also follow a safe titration schedule. Dr. Gangadhar Rath points out that the best site for insulin injection is all three: the abdomen, the thigh, and the forearm. These three all are okay. In abdomen, you should stay about 3 fingers width away from the abdomen, and you can go right up till the end. So how we tell our patient is put 3 or 2 fingers next to the umbilicus, sorry, not the abdomen, the umbilicus. Avoid that area, but from there up till the stitching line of your shirt, you can go up till there. And remember to rotate the site every day. In the thigh, an easy way of explaining would be from the anterior superior iliac spine to the knee. Divide the thigh into 3 parts. Inject in the middle 1/3, in the lateral part. And also for the forearm, for the arm, not the forearm, for the arm over the deltoid, you take the patient's shoulder prominence and the elbow prominence. Divide that line into 3, and you can inject in the middle 1/3, again on the outer surface over the deltoid. It has to be subcutaneous, not IM. So not forearm, it should be the arm. Dr. Rath also says about cleaning the site. So if the skin is socially clean, that means you are willing to touch the skin, shake hands with it. There is no need to clean the site. But if the skin is not clean, let us say it is dusty or there is dirt on it, then we have to clean with whatever is available. We can clean with water or with spirit. If you are using water or spirit, just wait for a few seconds for it to evaporate before injecting. Otherwise, the pain will be more. Basal bolus means we are giving at least 4 injections, 1 basal and 3 bolus. Sometimes 5 injections can also be given, 2 basal, like 2 NPH or 2 glargine, morning and night, and 3 bolus. Basal plus, on the other hand, can be classified as basal plus 1, basal plus 2. Basal plus 1 means 1 basal and 1 prandial insulin given at the heaviest meal. Basal plus 2 means basal plus 2 prandial insulins given with 2 heavy meals. And the moment it becomes basal plus 3, then we call it a basal bolus. If patient asks for, Dr. Ganesh says, yes, if patient asks for best treatment for diabetes, is it insulin barring theoretical indication? Yes, sir, the answer is right. If patient says what is the best treatment, as of today, it would be insulin. So that we can say confidently to the patient. Now, if the patient is doing very well on OADs, we will not force them to go on insulin. So what we'll say is, yes, insulin is the best, but as long as we can manage, we will do with OADs, and I am there to help you. So that is what you will say. We will keep on monitoring you every few months, every year. Whenever required, I will tell you well in advance. We also thank everyone for joining in, Mr. Tamang, Dr. Pradeep Rawal from Nagda Junction in Ujjain, Madhya Pradesh, Dr. Jayalakshmi, thank you for joining us. And the contraindication, I've mentioned one which I'm aware of now, that is PIK3CA inhibitors used in CA breast, but otherwise no other contraindication. Side effects, we have mentioned the local site reactions and hypoglycemia. Mainly, we have to beware of lipohypertrophy. We can do that by avoiding insulin injection, insulin syringe or needle reuse, and ensuring site rotation. We thank Dr. Anshul Singhai for being with us. He is doing a great job of managing diabetes in Chhattisgarh. Ashirvad asks us difference between Glargine U300 and Glargine U100. This is an important question. Glargine 100 contains 100 units of Glargine per ml. 300 contains 300 units of Glargine per ml. There is a difference in pharmacokinetics. Glargine U300 acts for a longer period of time, and the glycemic variability is less. The dose requirement may be around 10% more. So, but if you want a very long-acting Glargine or a very long-acting insulin, then the two choices are Glargine U300 and Degludec. These are the best choices available. Another question, this is coming from Chhattisgarh. This is which basal insulin analog is to be preferred in the CKD. So we can use anyone. I prefer to use either Glargine U300 or Degludec. The reason is that they cause the least hypoglycemia. So these are my personal preferences. When we are choosing an insulin regimen, we also have to be aware of not only physiology, pathophysiology, but also the cost. If sugar is not under control, Dr. Jayalakshmi, we can give insulin forever and ever. Now, it depends upon how the patient has come to you. If your patient is stable, you will tell your patient that glucose level will be stable. We will keep on giving insulin in almost the same dose. But as your beta cell function deteriorates with age, it has to happen. It will happen in everybody. Gradually, we will increase the dose, but it will be a very slow increase. On the other hand, if your patient comes in a symptomatic state, in a metabolically compromised, medically compromised, or surgically compromised state for whatever reason, then we will start with a high dose. But once you correct that compromise, once you correct the glucotoxicity, the lipotoxicity, the acute infection inflammation, then you will be able to de-escalate and bring down. So depending upon the situation that we are starting our patient on insulin, we can counsel him or her. We will give you insulin for a short period of time and then we'll bring it down. We'll begin your insulin. I'm not sure if we'll be able to stop it, but certainly we will be able to reduce the dose. Or for someone else, I think the pancreas is not working at all. We have to give insulin for a long period of time. Let us see how long it lasts and we'll cross the bridge when we come to it. This is a nice way of telling your patient and not scaring him or her. Dr. Gaurav asks about the site of injection. So let me repeat again. From the shoulder, Dr. Gaurav, up till the elbow. So you have this line and you divide it into three parts. Upper part and lower part, you leave it. The middle part you can take. And what I tell my patient is, from the crease of your shirt sleeve up till the stitching of your shirt sleeve, this is where you will inject. This is the outer one. This is the outer part of the middle 1/3. Do not inject here. Do not inject in the inner part. So do not inject over the biceps. So that is how we tell about the arm. Also remember that we have to go we should avoid going intradermal and avoid going intramuscular. You have to go subcutaneous. The thickness of the dermis is 2.2 millimeter. So just you have to make sure that your needle goes below 2.2 millimeter. And then you are in the subcutaneous space. Dr. Sanjeev Puri from the SUA in Punjab asks about Voglibose. Voglibose is a good drug for postprandial reduction. So if your patient is on high carbohydrate diet, not willing to stop the carbohydrates, then you can give Voglibose 0.3. It will reduce PP glucose by roughly 30-40 milligram percent and not by 100 milligram. So alone, usually it will not work. You will have to give in combination with metformin plus minus sulfonylurea. We've had lots of questions today, all various aspects of insulin regimens, insulin preparations. And this is actually something that takes a long time to master. I still continue to make mistakes. Sometimes I am not able to motivate my patient to take the right regimen. I try hard, but I'm not able to. Other times, I genuinely think patient will respond to basal or to premixed, but patient doesn't respond, then I have to up titrate or intensify next time. So what I would like to suggest is that whenever we are initiating insulin, do not speak in black and white language. Keep a window of escape open for yourself. So you tell your patient, Madam, I think you will do very well on this regimen. I'm quite confident. So let's see how you're behaving a week from now, 10 weeks from now, and then we take things ahead. Dr. Ganesh asks about pitting edema at the site of injection. It will not affect insulin absorption so much, but you just have to make sure that you are injecting in the right place. And if the edema is very severe, then you actually may have to take a skin fold and then inject. So, or you may have to use a relatively longer needle to inject. So, try to use a healthy site. A healthy site would mean one where there is no edema, where there is no infection, no ulcer, no inflammation. But if you're not able to find any site, let us say there is a lot of edema over the abdomen, then you can inject over the arm as well. Even the buttocks can be used to inject if you cannot find any other site. We use the buttocks in very small children, also in people with burns who don't have any other space for injection. Dr. Dheeraj Kumar posts a difficult question. Addison's disease with new onset diabetes. So Addison's is usually associated with hypoglycemia, and it would be rare to see 14% HbA1c and glucose of 500. But if it is like that, and now patient is unstable, and we will have to give steroid therapy, then certainly basal bolus insulin is the regimen of choice. Basal and bolus. In basal bolus, I would like to use insulin analogs. That is my preparation, because there is a higher risk of hypoglycemia in Addison's. So with analogs, I feel safer. The doses, if my patient is on prednisolone or methylprednisolone or hydrocortisone, then the glucose will be highest post-lunch and pre-dinner. So the afternoon dose of insulin will be the highest. So maybe my patient might take something like rapid-acting insulin, 8 in the morning, 12 in the afternoon, 8 at night, and maybe 20 units of basal insulin at night. So just that's roughly, but the lunch dose will be higher in such patients. We will tell the patient, don't worry, you will begin to feel good very soon. Within 24 hours, you will have an anabolic effect. Within 48 hours, sir, there will be a smile on your face. There will be a smile on your wife's face. Glucose will come down later. Don't worry at all. We are there with you. But you will begin to feel good first. Your infection, whatever comorbid condition you have, that will begin to resolve. And then your glucose levels will also come down. In general, the fasting glucose will come down later. The postprandial excursion will fall sooner. So with this, I'd also like to thank everyone for having joined us today. And we look forward to continuing this journey of education, of exploration, of learning, of fellowship together. Thank you for the opportunity to be part of your lives. And I'd like to also thank Team FDC for having given us all this opportunity. I would also like to mention the selfless service provided by Team FDC. Today, we have spoken of trade names because it was convenient. But have any of us realized that the people who are sponsoring this program have no medicine whatsoever for diabetes care, and still they are working in it, and they're doing it just for public good? So Team FDC, thank you from the bottom of our hearts. I thank you on behalf of everyone who is working in diabetes care in India. And I'd like to hand over the stage back to you.
Thank you, sir. One thing which I personally felt about this session was that those who will miss this session, I think next time onwards, like we've been promoting Dr. Vivian Fonseca's session, this session will be a bookmark session for the next up to 14th of August before we get Dr. Julio Rosenthal. So I personally feel, as you have also said, that the people will take time to master different sets of insulin regimen, which is commonly available and now newly available. And with the help of Dr. Kalra and the question answer which we get every week, I'm sure there are almost, see the numbers which we are getting around 6,000 doctors who are regularly watching it. On an average, there are 200 to 300 doctors who watch it regularly on live. But there are maybe in a week's time, this video will be reaching around 2,000, 2,500, 2,600. So overall, there are around 2,500 viewers every week. They are watching it in their convenient time. So this particular episode will be very, very helpful to them if they bookmark it and they continue to see in and practice. Nonetheless, this will be available for question answers as well, because we see a lot of question answer insulin regimen coming from doctors. So with this, I thank Dr. Sanjay Kalra for making it very simple. At the same time, giving us the confidence that he is there with us for another 50 weeks to take care of all the question answers. That's why, sir, we feel that every Sunday when you come here, all the doctors, who are around 6,000 doctors, are very confident that any question related to their family or their patients, they are ready to get an answer from you. Thank you very much. Good night and Jai Hind.
Jai Hind.
Jai Hind.